Okay, let's dive straight into this. Welcome to This Explainer. If you're currently prepping for your nurse practitioner boards, or honestly, if you just want to seriously sharpen your clinical pattern recognition, you are in the exact right place. Today, we're breaking down the ultimate cheat code for the NP boards. We are talking high-yield body systems, active recall, and those classic textbook presentations you absolutely must know inside and out.
All right, here's our rapid-fire roadmap for today. To keep from frying your brain, we've grouped these crucial body systems into logical chunks. First, we'll tackle cardiopulmonary emergencies. Then, we'll head up to neurology and ophthalmology. Next, we travel down to the abdomen, pelvis, and endocrine systems. And finally, we're going to wrap up with a lightning round of high-yield memory tricks.
Let's jump right into Section 1, Cardiopulmonary Emergencies. This is literally the life or death stuff. So right off the bat, I want you to think about this. What is the crucial, absolute deal-breaker difference between a patient who comes in with crushing chest pain versus one with tearing chest pain? Take a brief beat, lock in your answer. Okay, so here's why that matters. These two distinct clinical presentations dictate entirely opposite emergency treatments. If someone has crushing substernal chest pain, maybe it's radiating to their left arm or jaw, and you're seeing ST elevation on an ECG, well, that screams acute STEMI. And for a STEMI, time is myocardium. You need to move fast with primary PCI, aspirin, nitroglycerin, and anticoagulation. But if that pain is described as tearing and shoots straight to the back, especially if you notice pulse deficits or differing blood pressures between their arms, that is an aortic dissection. Treatment here pivots entirely away from blood thinners straight to immediate blood pressure control and emergency surgery for type A dissections. That brings us to our first major, absolutely crucial NP pearl. Tearing chest pain radiating to the back equals think aortic dissection until proven otherwise. Literally anchor that classic buzzword combo in your memory right now. If you hear tearing and back, your brain should immediately light up and think of aorta. Shifting gears just a bit over to rhythm, let's talk about atrial fibrillation. Patients will often present complaining of palpitations, feeling super fatigued, and you'll catch that hallmark irregularly irregular rhythm. And this brilliantly illustrates our next big pearl. AFib significantly, and I mean significantly, increases embolic ischemic stroke risk. Because of that massive risk, we can't just manage the heart rate and rhythm. We absolutely have to evaluate their need for anticoagulation by running a CHADS-2 DS2 VASC score. 5. I want you to burn this number into your mind when you're thinking about heart failure. A 5-pound weight gain in just a matter of days is a massive red flag that strongly suggests fluid overload. When your heart failure patient hits this critical threshold, you're likely going to see the dyspnea, orthopnea, crackles in the lungs, JVD, the whole shebang. And the immediate intervention? You've got to hit them with loop diuretics to pull that excess fluid right off, alongside their standard regimen of ACE inhibitors, beta blockers, and SGLT2 inhibitors. Now picture this. A patient rushes in, they're wheezing, highly dyspneic, and struggling to even speak. Classic severe acute asthma exacerbation. As your virtual coach here, I need you to know these immediate sequential interventions like it's pure muscle memory. Step 1, nebulized albuterol, get those bronchioles open fast. Step 2, systemic corticosteroids to shut down that massive inflammatory response. And step 3, oxygen if they are hypoxic. Remember, bronchodilators and steroids aren't wait-and-see meds. They must be administered immediately. All right, moving right along. Section 2, Neurology and Ophthalmology. In this section, rapid diagnostics are the name of the game. Imagine you're evaluating a patient who just developed facial droop, arm weakness, and speech difficulty. You're thinking acute stroke, obviously. But hold up, here is a critical pearl you cannot forget. Always obtain a non-contrast CT of the head before even thinking about administering thrombolytics. You literally must rule out a hemorrhage first. That imaging is 100% mandatory to determine if they are even eligible for those clot-busting drugs or a mechanical thrombectomy. Next up is a totally different but very specific kind of facial pain, trigeminal neuralgia. This presents as this sudden, intense, electric shock-like facial pain. It's wild because it's often triggered just by a patient brushing their teeth or chewing. So the crucial point here is, whenever you see that buzzword phrase, electric shock-like pain, you need to instantly link it directly to its first-line treatment, carbamazepine. Lock that pairing in. All right, we've got another magic number for you today. 1, specifically the 1-minute metric. If a patient experiences brief episodes of vertigo triggered by moving their head, and those episodes last for less than 1 minute without any hearing loss, that points straight to benign paroxysmal positional vertigo, or BPPV. You're going to diagnose it with the Dix-Hallpike maneuver, and you treat it with the Apley maneuver, but less than 1 minute is your golden clue there.
Okay, pay super close attention to this one. Acute angle closure glaucoma is absolutely not a let's wait and see situation. If a patient presents with severe eye pain, blurred vision, nausea, and they mention seeing halos around lights, you've got to act immediately. This is a true ophthalmologic emergency, requiring an immediate ophthalmology consult to save their vision. Period. Section 3, abdomen, pelvis, and endocrine. Let's head further down the body.
Let's kick this part off with the vasculature. Here is a massive pearl you'll see everywhere. Unilateral leg swelling after prolonged travel is deep vein thrombosis until proven otherwise. Seriously, if your patient just stepped off a 10-hour flight and they've got a warm, tender, swollen calf, don't overthink it. You order a venous duplex ultrasound immediately and start prepping for anticoagulation.
Now let's shift over to women's health, specifically managing hypertension during pregnancy. You need to have a crystal clear distinction in your head between what's safe and what is strictly forbidden just to prevent a catastrophic error on exam day. Your safe medications, labetalol, nifedipine, and methyldopa. But what is absolutely 100% contraindicated? ACE inhibitors and ARBs. Literally never ever prescribe an ACE inhibitor during pregnancy. Let's check out the GI system, hepatic encephalopathy. By definition, we are talking about confusion, personality changes, and asterixis, that classic flapping tremor of the hands. This whole altered mental status happens because ammonia levels are sky high in patients with liver disease, like cirrhosis. So to clear that ammonia right out of their system, your treatments of choice are lactulose and rifaximin.
Now, what's really interesting about this next slide is the highly specific language the boards love to use. Pain out of proportion to the physical exam. That phrase right there is the ultimate neon sign for mesenteric ischemia. Imagine a patient with a history of atrial fibrillation or atherosclerosis, and they are writhing in severe abdominal pain, but their physical exam just doesn't seem to match the severity of how much they're suffering. That mismatch is your clue. Think mesenteric ischemia and get a CT angiography fast. Let's rapidly review a few essential multi-system connections, because identifying these specific symptom combos is just pure gold for passing your boards. Localized crackles plus a fever? That strongly suggests community-acquired pneumonia. A super low TSH paired with an elevated free T4? Yep, that's hyperthyroidism. Fragility fractures? That points straight to osteoporosis, meaning they need a DEXA scan. Symmetric, burning pain in both feet that gets worse at night? Classic diabetic peripheral neuropathy. And lastly, pelvic pain with a fever and cervical motion tenderness? That is highly suggestive of pelvic inflammatory disease, which requires broad-spectrum antibiotics. All right, we made it to section 4, high-yield memory tricks.
Welcome to the rapid-fire finale. This section is designed purely to build that lightning-fast pattern recognition. We're going to train your brain to see the clue and instantly know the diagnosis. Ready? Let's hit these fast. Crushing chest pain with ST elevation? Think STEMI. Tearing chest pain to the back? Think aortic dissection. Sudden unilateral weakness? Stroke. Flank pain, fever, and dysuria? That's pyelonephritis. Calf swelling after a long flight? DVT. Here's a huge one. A smoker with painless, gross hematuria? Bladder cancer until proven otherwise. Low TSH, high free T4? Hyperthyroidism. Severe eye pain with halos? Acute angle closure glaucoma. Let's keep that rapid-fire pace going. Pain out of proportion to the exam? Mesenteric ischemia. Confusion with a flapping estrix tremor? Hepatic encephalopathy. Cervical motion tenderness plus a fever? PID. Burning feet in a diabetic patient? Peripheral neuropathy. And let's not forget our massive pharmacology antidotes. Warfare and overdose with major bleeding? You immediately need vitamin K and 4-factor PCC. And finally, for anaphylaxis, don't hesitate. Your absolute first-line treatment is intramuscular epinephrine.
Wow, okay, we have covered some absolutely incredible ground today in this explainer. So I'll leave you with this final, somewhat provocative thought. Which classic board presentation that we went over today are you going to consciously lock into your memory right now so you can save a patient's life tomorrow? Seriously, active recall is like a muscle. Keep flexing it, keep reviewing these concepts, and I promise, you won't just pass your boards, you're gonna be an exceptionally sharp clinician. Thank you so much for learning with me today.